Mrs. Bhupinder Kaur, Professor Maternal and Child Health, University College of Nursing in Baba Farid University of Health Sciences, Faridkot, Punjab, holding 28 years of experience. She has attended various training programs and workshops. She is also a member of Board of Studies of Baba Faridkot University of Health Sciences. So I request all three chairpersons to please come on the stage and take your seats as the chairpersons.
I would like to proceed further by calling the speakers. First of all, I would like to inform you all that due to unavoidable circumstances, Dr. Prakash Sama is not able to reach here. So the topic it will be discussed by Mrs. Jayanti P. Dholta. She is the former Secretary General of TNAI. Sorry, Mrs. Jayanti P. Dholta. Miss Jayanti P. Dholta. She is the former Secretary General of TNAI. Ma'am, please come on the stage and discuss about recent changes in midwifery.
Uh, First of all, I would like to thank the organizer. I would like to thank the organizer for having given me the chance because we are the people on the sunset side. So it's nice to see all new generation over there. And sometimes this also gives you the feeling of that you are still required. Thank you so much. Now, actually, I'm sure the much you may be knowing, but I know it because you are in the recent practice. So there may be certain addition which you can make, but I can give you my experience and what we have seen in the care of the mother and child. So home birth is not something, actually, if we see that most of us are born very normally. So my mother never went to the hospital or anywhere. She delivered 7, 8 in the house, and I think we almost are alive only. Not only alive, but well in the health and otherwise. But then definitely, though 90%, 95% women deliver can deliver normally and that they will have it in their own home. That is the best place for them because they have all known people around them. But there are only 5% or little more maybe there, which also is cannot be lost in a prime time, so which require also the specialized or advanced care. So that's how the new, as we say, we are all here when we are born only. So home birth has involved sorry, it is involved, but evolved as a technological advancement in medical and technological area of the health. Emerging people expectation of health. Though your home may be very comfortable, but you still like to be under the care of a specialized person or better person. Now, what is it now that mother and child death rate should reduce? Now, that is it is a concern not only of a family or a community, but it is a global concern. So United Nations has adopted the goals that 4 and 5, which says that mother and child death should come down, and also the children death under 5. Now, if we see the evidence which has come, which has given us the opportunity to go for a better midwifery techniques. Now, in this millennium goal itself, we can see there are a country in the Asia, or we can say in our neighbor only, like Bangladesh and Sri Lanka. So their MCH statistics is much lower than our, though we are better developed than them. Our health system somehow dilated in the realm of providing health for all. Now, in the realm of providing health for all, there are many type of the community care worker has come out. And recently, it is the ASHA. With the ASHA introduction, the emphasis was that all mothers should deliver in the hospital without giving any due respect or any due care for the infrastructure. They like to be delivered in the home, in the hospital. Instead, making infrastructure is not very easy. It should have been to strengthen their home care. Now, main things by which we try to do this is through the antenatal care, intrapartum care, and postpartum care are the important aspect of the woman's health. Now, in that there is a certain standardization which we need to follow. I'm sure here almost everybody knows that. And this also goes with the evidence goes on changing, so we should follow those things. Now, what the important thing, as a midwife, we need to do, and we also should see that how we make our presence among the people, because it is the people who recognize us. So that means we should be very careful how one woman differ from the others. So recognition of the uniqueness of woman in pregnancy is very important, because unless that is there, the woman may not come out what is stressful to her fear, her stress. I think the previous presenter has said that how the stress and fear can affect the pregnancy, and they could be reduced. The evidence based midwifery care management is very important, and the evidence, as we know, give us an idea the what is the reason behind it. So that provide us insight into the reasoning. So there are many evidences based and they are being used, but sometime I give you the example that in my time, that is in 50, 60. So during that time, though before that I have seen in my house that the woman delivered herself with the birth attendants. But in the hospital, we were told, put her in the lithotomy position, and when suck the baby's mouth and don't give anything for some time. Now those things have changed now. Now our emphasis is means that to put the child on the breast immediately, and also the exclusive breastfeeding for first 6 months and continued for 2 years. But earlier it was not so. It was even later on also, after 4 months you can start the baby uh, the on the supplementary food. Encourage non-interventional birth. It is nurses who are in the nurse midwife who are in close contact with the mother. So sometimes I have also seen a mother who says, no, I will go to such and such doctor because I don't want to have a pain during my birth. So the nurse or midwife who is with us should encourage that this is a normal process and it is a enjoyable process, even the celebrated process in the family. So therefore, I think when 90% can deliver normally, they should deliver normally through the normal process instead of undergoing any intervention. Now, another water birth. I have heard about it for many times. I have seen the demonstration also. But somehow in our country, this is neither taught nor practiced. Reason may be that the facilities, maybe the institution like this can introduce such kind of a birth so that the people get idea how what it is like and how it is beneficial for mother and the child. So as I said, home birth is a family celebrated events and one feel more comfortable in their own environment and uh, that hasten their pregnancy process. For that, for a, say, in the family, the woman is familiar with her birth attendance. Sometimes we say that she delivered me, she delivered my child, she delivered somebody else. So birth attendants have been from very beginning with the mother. Though now we claim that institutional delivery, it is a statistics which shows that 60 to 65% births are happening in the institution. Let it be PHC, CHC or a hospital. But still this 30-40% are delivering in the home and that too especially in the rural area. Now what they require, home delivery is good, but they require a supervision to help them to have a safe motherhood, and if there is any abnormality to convince them that they need the advice or they need to go to some places where they can be have a safe delivery. Then another thing is also empowerment of women. So it's not empowerment of woman, it should be empowerment of the couple and also the family, because it is they who take the decision. Otherwise, it becomes something somebody impel them to go to this place or remain in the house. So they should be empowered, they should make their own choices that where it is better for them, they should go for the delivery. Who should be with them, who should they consult, should be their concern. Now, in after birth, it is also well known. Earlier, my time, it used to be as soon as the child is born, he's taken away in the separate thing. He's completely washed and kept in a separate. Now, it is a well-known fact that skin to skin touch and putting the child on the mother breast within an hour of delivery are said not only help their bonding, but it also mother for the evolution of uterus and later on prevent chances of cancer and also for the child more, his suckling reflexes are more in the first 20 or 25 minutes of the delivery. Now, elimination of the myths is also very important. Especially in the rural area, the people feel that first breast milk is not should not be given. And in some community, they also feel you put the this one insect. Take the milk in a spoon, put the insect in that from both the breast. Where the insect die, that breast should not be fed. So that is not so. Now, why the insects die is a different thing, but mother milk is very important, and we know that it's for the child who had the who's take the colostrum, help them to prevent many diseases. Or it is also said that it is now also. I think if you really make the survey, you will find, say, after 6 months or say 1 year, the mother stop feeding the child. She says now that he doesn't, even child try to get the breastfeed, but they don't want to feed him. She will put something by which the child do not suck. Now that should be said that breast milk, if child get as long he want, is much better than the stopping him not to taking breast milk. So with the other food, then it itself gets reduced. Immunization also an important thing, but we have seen that with the immunization now, India is free of polio. And we have seen also very limited, or I haven't seen, in fact, previously we had even a ward for tetanus cases. Now there is hardly any hospital has that. So these things are reduced through the immunization. So mother also needs during pregnancy and child needs a schedule which is put to use should be uh, and should be followed religiously, I will say. Then the emerging technology in midwifery care. I think if we say the use of information technology, it has come in many ways, like your smartphone or online networking, digitalization. And I think I read the WHO report where they found that in Bangladesh they use this immunization technique, this one online, and they connect with the reduces. Then advocacy is very important to speak for the mother and child, and also for the profession is important. Unless midwifery profession is strong, the change can then only come. And then is the partnership. So here it is not a one person family or nurse or doctors. It is a total participation of the uh, uh, family, community, and the medical people, healthcare provider. Uh, and then social networking is also very important. Thank you.
Thank you, ma'am.
Thank you very much for your talk. It was so interesting. And I particularly enjoyed that you brought in the World Health Organization Millennium Development Goals. They're so very important, and we should all be following them. I mean, there's a whole body of research structured around the MDGs, and I was really glad to see you bring that up. It was a very interesting talk. How would you see maternal child health care improving in India? If you could say, in India we should do 3 things or 1 thing, what would they be?
Uh, your question was how child, for a child in the uh, child care, actually it is only the midwife who take total care of the child and the mother. Otherwise, obstetrician deliver the child, put their pediatrician comes to take care. It is only the midwife who take care both of them. So now, what is now, which is in the modern time now, it is assumed that one thing, when the child, let the mother assume any position she is comfortable. Whether she wants to stand, she wants to sit, or lateral position are better than the lithotomy position, because lithotomy is convenient for the midwife, not for the woman. So as soon as the child is born, he can be put on abdomen, made to suck the breast, and see that let the placenta till it is pulsate. When it stop pulsating, then separate the mother and child. So that give them the better thing.
Thank you very much. I think with the recent or latest technology advance, being a nurses, we should, I think, leave those all old practices or procedure in our nursing also. Like nowadays, no eye care is given to the baby also, because it leads more infection to the baby. Even cord care is not, nowadays we are not doing. If some hospital in some they are doing, that has to be stopped for the sake of prevention infection to the newborn baby. Thank you very much. Well done.
Now let us discuss about the latest management technique by midwives through panel discussion. The members of the panel discussion are, first one, Dr. Bandana Das, presently working as principal in Neotia Academy of Nursing, Kolkata, with distinguished and eminent experience of nearly 40 years in this field. She's a president of SOMI at national level, and she has done 18 months post-graduation program as advanced midwifery practitioner, that is independent practice conducted by Government of India under INC. She organized and attended various conferences and research projects. In 2008, she received National Award from President of India for her commendable work. She participated in various educational activities in our country as expert. She worked as Vice President of SOMI under NRHM. Ma'am, please come on the stage. The next member is Dr. Sendra. Dr. Sendra Friedman, Assistant Clinical Professor at Drexel University, Philadelphia. She worked as nurse midwife for 30 years. She holds a Master of Science in Maternal Newborn Nursing from Yale University, USA. She currently serves as Vice President of the Princeton Regional Health Commission. She is also a member of Robert Wood Johnson Transdisciplinary Simulation Team, where she has opportunity to work with undergraduate and graduate nursing students. And the last member is Dr. Darshan Sohi, Principal in Chief Khalsa Diwan International Nursing College, Amritsar. She is having 36 years of experience, and she has done various publications in books and journals to her name. Welcome you all. The time limit for this session will be 20 minutes.
Thank you, everybody, and I must express my heartfelt thanks to the organizer to give me this opportunity to be here and to exchange and interact with you. So, childbirth itself has not changed at all. Besides, babies are still born today in the same way that they have been born for generations. But what changes we can see? That changes is the change in the expectation of the mothers, that approach has been changed. And also the technology has been changed. Some of the technology has been adapted from the developed countries. And another thing change is the economic condition of the family and the country context. Also the technology used during pregnancy and birth. So that what all changes we can see nowadays in India, that actual that pregnancy and the childbirth is a normal physiology. Actually nothing is very different or abnormality. Actual mothers are normal, pregnancy also is normal, delivery also is normal. So it is a total component, that is the holistic approach. We are not treating a patient, we are giving the care to the mother. So it's a not only the physical care, physical, psychological, emotional, and social and spiritual aspect. We are considering all the component of a individual. So what they need during pregnancy, that pregnancy, actual caring women during pregnancy is the responsibility of the midwives, also the childbirth and the during postnatal period, and treating complication due to miscarriage and unsafe abortions, providing newborn care, that is a very important aspect of the responsibility of the midwives, and providing pre-pregnancy counseling and also birth preparedness counseling, recognizing and addressing problems in the woman before, during, and after childbirth. That's a very important area. As a midwives, we have to consider that part. Assisting women to successfully breastfeed, that has already been mentioned by Madam Dhaulata. So these are the areas, and what all changes we can see when we are giving the position during delivery. Usually that is the mothers are lying on the supine position, but now we prefer to have the squatting or the other position. Any position mother can adopt during delivery. Another thing is that is the mother should have undergone 4 antenatal checkup, and including registration. That also registration, early registration is considered. It will be benefited by the mother, as because when mother is registered early, within the 12 weeks, we can find out the complication throughout the pregnancy, and also we can give the care to the mother, and also we can prepare the mother for or the delivery and also the postnatal. And also that treat backache and speed up the labor, and also maintain the partograph during labor, so that we can identify the complication during labor, and we can and transfer or the refer the mother to higher center, so that we can save the life of the mother and the baby. Use hot and cold compresses with and without rolling pressure on her back, lower back. That is also one thing. And we don't, nowadays we are not encouraging the midwives to give the episiotomy to all the primipara mothers. Let the mother have these are no first degree tear or second degree tear, but not the episiotomy. Also, saving the pubic hair also nowadays discouraged, and also giving the enema during labor. That also is a procedure we usually do. And also allow the mother to roll the birthing ball, so that mother can be the relaxed during delivery. So that process also we can allow the mother to work for sometimes with the walker. Also use pelvic squeeze to alleviate the pain on the back labor,
and also reposition of the sacroiliac joint. Do gentle lymphatic drainage and stroking towards her heart so that mother can feel better without tiredness. So that another thing, and for the this one, no, Madam Rina Bose has mentioned the nurse practitioner in midwifery course. We have done that course. That they have learned the special skills in the specialized. Actually, the ICM competency, there are the 7 areas are there. Out of 7 areas, that is competencies or the basic competency for giving the care during pregnancy, during labor, and afterwards. So other than this additional competency that can be acquired by the nurse practitioner midwives so that they can do the specialized procedure. So the procedure that they can do the pap smear examination, they can do breech delivery, they can apply the outlet forceps if required. Also, they can apply the vacuum extraction, manual removal of placenta, and drainage of the breast abscess, collection of sample for culture. Also, they can insert the ring pressuring for the cervical prolapse, as well as they can do the manual vacuum aspiration. These are the specialized procedures, and they have been taught and they have been practiced in the clinical area so that they can do those practiced. Also for the newborn, they can do the assisted ventilation of bag and mask, also chest compression, and also the this one no securing IV line, and also kangaroo mother care that has already mentioned by Madam Dhaulota, and also they can do the nasogastric feeding for the newborn. And nowadays that most important part is the counseling, that is the during pregnancy, also before pregnancy adolescence counseling also is very important to that can be done by the midwives. So these are the special procedure. Other than some of the procedures are there that cannot be practiced in our country, but developed countries they are doing those procedures. So this is all about the this one no that new procedures. Actual nowadays the change we can see the most of the cesarean section is the elective cesarean section. Actual our this one nurse practitioner they are not trained in that aspect, but we have seen the countries like Mozambique and Ethiopia they are not midwives are doing the this one no cesarean section also. So for that reason they are getting the special training and they are doing. Even the Bangladesh they have started the 3 years of midwifery direct entry midwifery course, and their midwives are very strong and they are also doing some of the special procedure which are mentioned in the ICM competencies. Thank you.
We focus a little bit and talk about the importance of breast health for nurses, nurse midwives, physicians, and all members of the healthcare team. So students in the back, listen up, because for all of the audience, we've prepared a short 5-minute scenario, a simulation on stage. We need a health history taking, and Jamie has volunteered to be what we call a standardized patient. She's been trained, and she will act as a patient, and she knows what I am going to ask her and how to answer. And I'm another participant in this simulation. I'm the healthcare provider as a nurse midwife. So as I perform the health history, I'd like all the members of the audience, my goal is to have you identify 2 or 3 risk factors for breast cancer that I may elicit during the health history. Good morning. It's such a pleasure to meet you, Jamie. It's your first time to the clinic?
Yes.
And, you know, I know we have a lot of paperwork outside. Oh, good. So I'm glad to hear that you come every year. And I'm just going to ask a few more questions. So medically, do you have, I see on the chart that I think you have someone may have cancer in the family. That's what you wrote down.
Yeah, I don't have any health problems, but my mother has cancer.
Okay, your mother has cancer. But for you, you don't have any heart disease, diabetes, seizures, any history of blood clots, anything like that?
Not that I know of.
And I see you have never had a surgery in your life?
Correct.
Okay. And you mentioned, I'm going to talk a little bit about your gynecologic history. How old were you, Jamie, when you had your first period?
I think I was 10.
Okay. And any problems with your menstrual cycle now?
Nope, they're regular.
Okay, good. So you were 10 when you first had your first period. Good. And in terms of the other parts of your reproductive, your physiology, have you had any problems with your ovaries, your tubes, your breasts?
Nope.
No. Do you do self-breast examination? Like every month, palpate your breasts for any signs or symptoms or lumps or bumps?
No, I never really felt comfortable doing that.
Okay. So I'm glad you told me that because we can hit upon that a little bit more later, and I
Okay.
can teach you how to do a self-breast exam. Now I see that your obstetrical history, you've had one baby, a vaginal delivery, you had a boy,
Yes.
no problems, right?
No.
Did you breastfeed?
No.
No, you didn't
No,
want to?
I wasn't interested.
Okay, good. And family history, you brought up that your mom had cancer. Do you know what kind?
Breast cancer.
Breast cancer.
And my grandmother has breast cancer as well.
Okay, so your mom and your maternal grandmother had breast cancer.
Yes.
And how about in your dad's side, any cancer there?
Not that I know of.
Okay. And just a few more questions. Are you on any medications?
Nope.
Do you have any allergies to foods or medication?
Nope.
Smoke cigarettes?
No.
Okay, and how about alcohol use, like wine or beer or hard
I
liquor?
drink wine.
Oh, you do? I do too a little sometimes. But how much do you drink? Would you say on
Um,
every day?
Yeah, about 2 glasses a night.
About 2 glasses of wine a night. Okay, excellent. So I'm going to conclude our little simulation, and you can see I did a very quick history. You can stay, Jamie. And one key factor is I mentioned that Jamie did fill out paperwork in the office, but that I did take the time, and as nurses, all the nursing students, listen up, nurses and nurse midwives and every healthcare provider needs to take the time to go through that history again verbally, because oftentimes patients forget and or might not want to write something down, and they feel more comfortable as they get to know you, talking about it. So within this history, there were some very clear, identifiable risk factors for breast cancer. And when I mention risk factor, I'm saying that anything that affects a person's chance of getting breast cancer. It does not mean that you will. It just raises our awareness and alerts the healthcare professional to teach a little bit more and to teach the patient about those topics. So for students or anyone in the audience, could we identify 1 or 2 risk factors for breastfeeding in that history? Raise your hand, don't be shy, don't be shy. Yes? What's your name? Isaac? Excellent, yes. There's a history that Arthur said, mother, it's that close, relatively. There was no family history on the father's side, but remember, we always ask, because believe it or not, men can get breast cancer, and it is a link to our actual patients, so we need to, that's one. Can someone give me a second? She did not breastfeed, yes. Excellent, Arthur, you've been studying. But yes, not breastfeeding is a risk factor. And I think it has to do about the number of cycles, menstrual cycles a woman is having or not having, and certainly when we breastfeed, we have a decreased amount of menstrual cycles. with less exposure of estrogen and progesterone in our body. So that's two. And so thank you, Arthur. And I'll go over the other ones that are in that scenario. One was early menarche, when she had her first menstrual cycle at 10 years of age. So anybody that starts before 12 years of age, it is a risk factor. Secondly, you noticed when I asked 1 to 2 glasses of wine a night puts you in a different risk category. And I didn't ask her, but I know that she's African American. And she wrote that down on her intake, and I know she's African American. And African American women, when they're under 45 years of age, which she's 30, puts her in a little high risk category. So what do we do with all this, and where do we go? This helps risk. It helps us with diagnosis, but more importantly, it helps with one key thing: understanding how do we help raise the awareness in our patient without frightening, without saying you're going to get breast cancer. It helps inform us that we need to teach a lot in this area. So we might pick 1 or 2 of these areas, and we're going to start with self-breast exam to do the teaching, because that's a key thing that she needs to start doing, or hopefully bring up to her awareness, up to the importance. And with that, I'm going to thank Jamie and our little part of this presentation, and our will demonstrate self-breast exam.
Community teachers in India, unfortunately, 50% of all breast cancer patients could obtain prolongation of survival by increase of public awareness regarding breast self-examination. So, it can be detected in early stage and prognosis will be good. Breast self-examination is an important, cheap and easy, but lacking lies in the field of creating awareness. Optimum screening for breast cancer includes triad-off screening techniques, that is clinical examination, mammography and breast self-examination. Mammography is very costly and each woman cannot afford, so breast self-examination is the best method to detect in early stage. The current recommendations by American College of Obstetrician and Gynecologists and also American Cancer Society are for breast self-examination recommended that breast self be performed once a month after the age of 20 years. Why I topic for myself personally suffered with this disease in 1997, 14 years ago. I was gone under this treatment of surgical treatment, medical radiotherapy and chemotherapy. No, it is our duty, it is our concern to make other people awareness so that they cannot suffer like me. This was my research presentation. This is introduction. I will not discuss regarding introduction. Already I have discussed. And an ounce of prevention is worth a pound of cure. Statement of the problem was an evaluatory study to assess the impact of structured teaching program on detection of breast cancer by breast self-examination among the teachers selected in selected schools of This was the purpose to make awareness. Objective is to assess the pre-test knowledge, then to equip them with knowledge how to do the breast self-examination. Then post-test was also done. Relationship was found among variables. This was the conceptual framework, Ludwig theory, review of literature. It was the quasi-experimental study. Population, I took 700 teachers, 700, it was 400. Then level of knowledge grading was done according to excellent, that is more than 80%, good 60 to 80%, average 40 to 6%, then below average. Now come to the results. This is all characteristics of study subjects. They were well educated, most of them were married, they have one or two children, they were in the age of 20 to 55. And this is the main finding, pre-test and post-test. See the results. This is considered as well-educated community of well-educated women. Level of knowledge, only 2% have excellent knowledge, whereas after STP in post-test, it was jumped to 42.5%. It means the benefit was there. Good knowledge, it was only 11%, and after STP, it was 50.5%. Then average, few people have average knowledge after giving STP. Before, average knowledge was about 50%. This is again pre-test, post-test knowledge. You can see the difference. Mean knowledge, there was also a difference between mean knowledge, mean and SD both. It is mean knowledge, pre-test, post-test. Difference you can see. Then conclusion, the knowledge level of teacher was average and below average before imparting the structure teaching program, but good and excellent after imparting the structure teaching program. The difference between pre-test and post-test knowledge score was statistically significant, and variables like age, education, previous knowledge of breast self-examination had impact on the knowledge. Other variables have shown no relationship. Then this is all recommendation. Now come to the technique of breast self-examination, which is very simple and need no technical the definition. This is the breast self-examination. We all know is a technique for checking one's own breast for lump or suspicious changes, or we can say it is a systematic way of detecting breast abnormalities. Then purpose of this benefits, breast self-examination should be performed monthly in order to discover changes in breast tissues, onset of pain in breast area. 80% of lumps are not cancerous, although breast cancer is usually breast self-examination is performed by person itself, but doctors and health professionals including midwives can also assist in performing the breast self-examination. Nothing special is required for breast self-examination, only one mirror, a pillow for head and shoulder, privacy, time needs 5 to 15 minutes, best time after menstruation. A girl should start performing at teenage, describing the requirements of breast self-examination. Women between the age of 20 to 40 should have clinical breast examination after every 3 years also. This is the step. There are two main components of breast self-examination. One is inspection, visual examination, or second is the palpation. Number one, make a regular date for your breast self-examination if you are pre-menopausal stage. Set a regular time to examine your breast a few days after your period when hormone levels are relatively stable or breasts are less tender. If you are already menopausal, have not pick a particular day of the month to do this examination, then repeat the BSE on the same day of next month. It is visual examination. Stand before a mirror, see both breasts at the same time, stand with the hands on the hips and check the appearance of the breasts. Look at the size, shape and contour. Note changes, if any, in the skin, color, texture. Look at the nipples. These should not be inverted. Then we should see the protrusion or dimple in the breast. Then third step, visual examination. It is again still standing in front of the mirror. Raise arms overhead. See if breast moves in the same way. Note any difference. Look at the size, shape, and any dimple. Checking for symmetry. Pay attention to the nipple areola to see any dimples, bumps, and retraction of the nipple. Look towards armpits, axilla. Note if there is any swelling at lower armpit area. Then it is manual examination. Next step, manual examination, raise left arm overhead. Use right hand fingers to apply the gentle pressure. 3 finger pad should be used for gentle pressure. Stroke from top to bottom of the breast, moving across from the inside of the breast all the way into the armpit area. We can use circular motion from inner, from nipple to outer side of the breast. Take note of any changes in texture, color or size. This is best done in the shower as with wet skin will have least resistance to friction of the fingers. It is the next step, squeezing the nipple. Lower both arms with index and middle finger of right hand gently squeeze the left nipple. Note whether if there is any discharge. It is the last point. This is best done in the bedroom where we can lie down, place a pillow on the bed, lie down and put your left hand behind the head. Use right hand to stroke the breast, underarm as in step 4. Take note of any changes in the texture, color or size. Conclusion, breast self-examination is one of the easiest method to prevent breast cancer. The knowledge of the teacher, nurses, midwives has an important role in the society. They can perform breast self-examination. They can provide the knowledge to the rural women and urban women. This breast self-examination costs nothing, but it pays a lot. Then, thanks. I, at last, I owe my head in front of Badu Sahib Gurdwara institution. This is also known as land of meditation. I also owe my head to Babaji, Sant Iqbal Singh Ji, who has given us blessings. I came here 4th time. It is my 4th visit to this holy. Then I want, because of Babaji, because of Kalgita Trust, we are here in the Valley of Divine Peace. So I will say thank to all the trustee of Kalgita Trust, Dr. Atwal ji, Vice Chancellor, Dr. Devinder Singh ji, Dr. Neelam Kaur ji, Dr. Harpreet Kaur ji, Madam Ranjit Kaur ji, Madam Chakrabarti, and who has given us the platform to meet such senior personalities in the nursing profession within the country or from international level personalities who have come here. We took this opportunity due to Kalgita Trust only. So I should say thank to all and thank you for your patience to listen me. Thank you.
I would like to thank all the three speakers. They have nicely covered the topics which are assigned to them. So firstly, I would like to thank Ma'am Bandana Das for highlighting our midwife, a simulation of his and thing for ourselves. How many? So only one single person is there in the hall. So we can see that what is our knowledge level and what we are performing at this point of time. So once again, I thank all the three speakers.
Thank you all for sharing your deep knowledge about latest management technique by midwives. So your session was full of enthusiasm and valuable knowledge. So now various nursing national, international and state level. Next chairperson is Dr. Mary Lou, graduated from Teachers College of Columbia University, New York. She is teaching nursing since 1973. She has been administrator in BSc Nursing and Master's program. In November 1993, awarded as Nursing Education Award in Pennsylvania by Nurses Association for major contribution to advancement of nursing education. In 1997-2000, appointed as a commissioner of National League for Nursing Accrediting Commission, the newly formulated accreditation body for nursing program. She made many invited publications and presentations, and one of that is a message to facilitate articulation of advanced nursing students into registered nurse and BSc nursing completion program. And the research was Pennsylvania nursing as well. So now this.
Now the speakers, it will be my honor to invite Mrs. Seema Barnabas, Vice Principal and Professor in CM Punjab, having 30 years of experience in this nursing field. She has served military nursing services on Army Corps for 5 years in her service time. She has supervised and coordinated various hospital activities, presented and published various journals. Ma'am, please come on the stage and share your views regarding utilization of current approaches in the management of sepsis and septic shock.
Before she starts the session, a very good afternoon to one and all present here. Such a knowledgeable conference, and the way they gather the national and international midwife nurse researchers galaxy in this value-based education valley. This is really salute to this organizing committee who have organized such a very wonderful. And I am very thankful to Professor Sujana and the organizing committee who invited here and be a part of this conference. Thank you so much.